on that stuff, infections and stuff with white blood cells today, but we're really not going to get into the nitty gritty until we do chapter 22, which is the lymphatic system. All right. Formation of blood cells. Where are blood cells made? Red bone marrow. Are all blood cells made in the red bone marrow?
Yes.
Red bone marrow. Yes.
Whoa.
Got it.
You all right?
I don't know.
What are your
Anyone
symptoms?
Yeah, is there an automated defibrillator in here? All right, there you go. So yes, they're all made in the red bone marrow. Why is it called red then?
Because it looks red.
Because it looks red, because there's more red blood cells than there are the other types. We did talk about the red blood cells in detail last week. What's the other name for red blood cells? Erythrocytes, good. And what's the main function of the red blood cells?
Carrying O2.
Carrying oxygen, right? What's special about the structure of red blood cells? What are some features that are special about red blood cells? Well, they can squeeze through, and what's the shape that they have?
Donut.
A donut.
The donut shape or the biconcave disc shape, right? That helps them squeeze it. What's also special about, like, what's inside of them? Or what's not inside of them?
No nucleus.
No nucleus, no real organelles at all, right? So they're pretty much empty of organelles and a nucleus. Instead, they're just filled up with lots of what? Yeah. Yep, it's hemoglobin. You're still so polite. He's always right. All right. Beasts jump all over him. All right. So anyway, there's hemoglobin that carries the oxygen, and that's what's packed inside of the red blood cells. How much hemoglobin is in one red blood cell? 280 what? Million molecules. All right. Not 281, not 279, 280. Okay. So fine. That's enough review. So today we're going to start with the white blood cells. Talk about them. What do white blood cells do? They fight off infection. Then we'll talk about platelets. What do platelets do?
Blood clotting.
Yeah, they do like blood clotting, or there's a broader term for it. Anyone know the broader term for like preventing blood loss? Hemostasis, thank you. So they are involved in blood clotting, but that's just one aspect of hemostasis. We'll talk about all of hemostasis actually when we get down to this part, all right? Stem cell transplants from bone marrow and cord blood. So people that have diseases of their bone marrow, such as leukemia and other diseases, they're going to have problems making their blood cells. And so oftentimes as a treatment, you have to give them new bone marrow from someone else, or you can also get it from what's called cord blood that comes from the umbilical cord, and we'll talk about that. Then we'll talk about hemostasis, we'll revisit what the platelets do, but we'll get more into blood clotting, which is a series of chemical reactions that are going to help prevent blood loss. And you're going to have to memorize the big picture on blood clotting. You're not going to have to memorize every little step, but there are like three main stages that you definitely should memorize, and I'll help you with that. Then we'll get into the blood groups and the blood types. Who in here knows what their blood type is? Wow, is that it? Just really you? Oh, you do? Okay.
Supposed to know?
Supposed? I mean, I guess it could be useful if, like, I don't know, you're dying and someone says, what blood type are you? Like, well, you could like say it as you're dying or something, I guess, and maybe it would save your life versus if you don't know, then be like, it's too late. What's that?
What's yours?
You tell me yours first.
Okay, wait. I know my mom's O.
Okay.
All right, I'll pull out a pundit
I
for you.
think my dad is, I think he's AB. So,
Okay.
Oh, it got complicated.
Well, okay. Yeah, that does get complicated. It's hard to really know what you got then. Is anyone? So you don't know what you've got, but you know what your parents have?
yeah, because I have their own medical information. No, that's why I have it. It's not, I didn't even go through like digging.
No, of course not. No, of course not. Who knows what their blood type is? What's your blood type? Oh wow, that's pretty exotic. Nice. What else? What's yours?
I'm O positive.
Yeah, me too. I'm
Or
actually O
O
positive.
positive.
Yeah, there's a lot. Who else knows their blood type in here? Anyone else? I can't believe I'm really shocked. The class.
How do you find out?
If you donate the Red Cross, then like naturally like.
Yeah, like if you donate blood, you can ask them like there sometimes. No, you don't donate blood. Yeah, don't help out. Yeah, good. Just yeah.
They won't take mine.
They won't take yours.
I'm anemic.
Oh,
That's for your own
okay.
safety.
Yeah, that's probably a good thing. Yeah, you don't want to lose any more blood than you already have, right? So that's a good thing. All right, anyway, we'll talk about the different blood groups here. We'll talk about the ABO system. That's what gives you the letter part, the A, the B, or the O. And then there's also the other part of blood typing, which gives you the word positive or negative, and that's based on a different factor called the RH factor. We'll discuss all that when we get there, and then we'll finish up with some blood disorders. All right. So on to the white blood cells. Where they are. There they are. In lab today, you're going to get to look at blood smears under the microscope. I went kind of long with the lecture this morning. Hopefully I can get through faster so you guys have more time. But you get to look at blood smears. You know, try to find all the different types of white blood cells. Don't just go for the money. Don't just try to find the basophils, all right? But look at all the other ones. You'll also get a chance to do some blood typing with fake blood that's back there. I have one out that I did from the class this morning, but there's a whole bunch of other fake samples that you could test to kind of see what they are, and I'll show you how that works too. Anyway, white blood cells. The other name for white blood cells is leukocytes. What does leuko mean? It means like white, and then cyte means what? Cell. Don't ask me why they're not called albinocytes. I don't know. I don't know. Anyway, now white blood cells, they're going to have like the regular. They're going to have all the organelles that you'd expect in regular body cells. They also have nuclei, right? In fact, you'll see in a second, they actually have some weird shaped nuclei, okay? But they don't have any hemoglobin because that's not their job. Their job isn't to carry oxygen around, so they don't have any hemoglobin. The main job is to fight off bacteria, viruses, etc., and that's part of your immunity. And we're going to get into the nitty-gritty details about that in chapter 22, which is the lymphatic system chapter. Now, the way white blood cells fight off infection, they're not waiting, for the most part, white blood cells are not just waiting out in your tissues for an infection to show up. The white blood cells usually stay in your blood, and then when an infection's going on someplace, they'll get called to that area. And then what they do is they show up in that area, and they will squeeze through the walls of the blood vessels in that area. Okay, you haven't learned about blood vessels yet, but you will. And the cells that make up the wall of the blood vessel, they're called endothelial cells. So the white blood cells will squeeze between those endothelial cells to then get it out into the tissue where the infection is taking place and try to fight it off. Okay. Now, how do the white blood cells know where to go when there's an infection going on? Anyone remember? Well, it is part of the inflammation, but specifically what draws them to an area where the infection is. And I'll give you a hint. It's something we talked about when we also talked about how sperm know which fallopian tube to go towards. Yes? Chemotaxis. Yeah, thank you. Chemotaxis. Remember, that's chemical signaling that's attracting cells to an area. In this case, it's attracting white blood cells to an area where an infection is taking place. That process of squeezing through the walls and getting out, that's called emigration. It also goes by some other names that you should be aware of that I'll write up here. Anyone know another name for emigration? It's also called slide through. No, it's not called slide through. Sorry, that'd be cool if it was. It's called diapedesis. And it's also called leukocyte extravasation. That's what sucks about AMP. There's always multiple words for the same thing, usually. All right. So when you look at white blood cells, or when you talk about white blood cells, they like to put them into two categories based on whether they have granules or not. Granules are basically like they're kind of like vesicles. They're little bags that are inside of the white blood cells that contain different chemicals, and it depends on which white blood cell you're at in terms of what it's going to be inside of the granules. But some of the white blood cells have these granules and some don't. If you have the granules, you're called a granular leukocyte. If you don't, you're called an agranular leukocyte. What does the prefix A mean before things? Without. Yeah, it means not or without, right? So those are the guys that are without the granules. Sometimes they will shorten these names, and they'll call these granulocytes, right? It's kind of like a Brangelina type of thing, right? Where it's a portmanteau where you pull out the middle part and you throw them together. Or there's agranular leukocytes. Anyway, the granular leukocytes are these first three guys, okay? All the ones that end with the suffix "-phil. By the way, what does the suffix "-phil" mean? Anyone know? I stumped like the other classes one with this too. Well, go back to AMP1. What were hydrophilic solutes? They were ones that what?
Like water.
Love. Phil means love, okay? So at the end of like your letters to your whoever significant other, you just put Phil, comma, then your name, right? That's actually the first time I've made that joke. Wait, that's the first original joke I've done in 10 years. This is cause for celebration. I wish I could open the door and have like a party. Thank you. So much of this is just rehashing the, thank you. Wow, that felt kind of good actually. Still got it, can make a new joke. Anyway, so these guys, they all end with Phil, and I'll tell you what they're loving in each case, but they're named based because they sort of like something, right? And then the ones that don't have granules are the lymphocyte and the monocyte, okay? So when you look at this, the granules, at least in the eosinophil and the basophil, are pretty obvious. They're these big kind of chunky dots. Now in the case of the eosinophil, the chunky dots in the cytoplasm, they're kind of pinkish or they stain kind of reddish, okay? Whereas the chunky dots in the basophil, they stain more like dark purple or even black, okay? The neutrophil has granules, but they're maybe not as big as the granules that you see in the eosinophil and the basophil. So let's talk about these. Neutrophils, when you look under the microscope today, chances are after you see red blood cells, which you're going to see everywhere, right? You'll probably see neutrophils first. They are the most common. What's the next most common after the neutrophil? Remember what's the memory trick? What'd you say? I think you're right.
What is the memory trick?
Didn't I tell you the memory trick?
I don't think so.
Ah, you're sorry.
Knowledge.
The morning class is so much better than this class. They get all the good stuff. Yeah. No, I mean it's never let monkeys eat bananas.
You were right.
All right. Never means neutrophils. They're the most common. Let means lymphocytes. They're the second most common. Monkeys is monocytes. They're the third most common. Eat is eosinophils. And then bananas is basophils, which is the least common. So never let monkeys eat bananas. All right. Sorry, I thought I told you guys. So anyway, 60 to 70% of the white blood cells are these neutrophils. Why are they called neutrophils? What does that mean? Neutral means that the stain that they stain best with under the microscope has a neutral pH to it. The particular stain that sticks well to them under the microscope has a neutral pH, and that's how they got the name neutrophils. They like that type of stain that's neutral. Fine. The other name that you'll hear thrown around, that's maybe even a better name when you want to think about them under the microscope, is polymorphonucleosites. What does the prefix poly mean?
Many.
Many. What does morpho mean? Shape. What does nucleo mean? Just means nucleus. And then what does site mean again? Cell. So these are the many-shaped nucleus cells. And that's because they usually have these funky nuclei. Okay, that's one nucleus, but it's divided into little lobes. Usually it's divided into like 2 to 5 lobes. Okay. Another name that you hear for these guys, you may hear it thrown around at the hospital, or if you ever have a guest starring appearance on Grey's Anatomy, they'll probably call them polys. What's the poly count? All right, that's a short for polymorphic. It just means the same thing, right? But it's a cute way to say it, and they probably say it on the show. I don't know. Along with macrophages, neutrophils are great at phagocytosis. Okay, the difference between macrophages and neutrophils is neutrophils are circulating around in the blood, and then they need to be called kind of to the area and do that emigration thing to get out of the blood into the tissue. Whereas macrophages, they're already there. Macrophages hang out in the tissues long term, and they kind of wait in case any problems show up. It's kind of like the difference between like the local police force and the feds, right? The macrophages would be like the local police force, they're already there, and then the feds would be like the neutrophils that then have to show up and kind of help out or whatever. They're both great at gobbling up bacteria, viruses, etc. So that's why they're referred to as the major phagocytic cells in the body. Next, eosinophils. Eosinophils love eosin. Eosin is a stain, another microscope stain. Eosin has a red color to it, which explains why when these guys stain, they usually have these big kind of pinkish or reddish granules. Okay, because they love, that's what eosin is. Eosin has a pink-red color to it, and they love that color. Okay, they are the second least common cells. So today, it's going to be hard for you to find a basophil for sure. It's also going to be hard for you to find an eosinophil, but if you get lucky and you keep looking, you might find one. Eosinophils phagocytize antigen-antibody complexes. So basically, antibodies are immune proteins that can attach to bacteria and viruses. And when you have an infection going on, the antibodies attach. These guys kind of look at antibodies almost like seasoning on like a steak or something like that. When you have a bacteria that's coated with antibodies, these guys are really interested and they'll start to phagocytize it. They're also good against certain parasitic worms. Unfortunately, I do not have a list of the worms that they're good against versus the ones that they don't work on. So if you're planning on getting a worm infection tonight, just hold off. I will let you know what you're protected against. Basophils. So basophils, their name is because, you probably guessed it, they like a stain that has a pretty basic pH, a pretty high pH. And that stain happens to have kind of a dark purple, bluish coloration to it, which explains why they have kind of big blue, purple, chunky dots. Actually, you know what? I forgot to tell you one thing to help you out. Sorry, let me just go back to the eosinophils for 1 second. So when you look under the microscope at the eosinophils, look for the big chunky red dots, number one. Number two, this is their nucleus. Now their nucleus has lobes the way that neutrophils, their nucleus has lobes. But eosinophils' nuclei almost always has two lobes. It's a bilobed nucleus. And so some people will describe the nucleus of an eosinophil as looking like headphones or earmuffs. So if you see a headphone or earmuff shaped nucleus along with big chunky red dots, think eosinophil. Basophils, big chunky dark purple or even blackish dots. That's a key feature. Notice that you really don't even see the nucleus. It's kind of a amorphous nucleus. It's really hard to visualize the nucleus, but you do have, mostly because you have just these big chunky dots that are all over the place. These are the least common. I honestly can't remember the last time a class found a basophil. Maybe it was 3 years ago. It's been a while. Those granules have a number of inflammatory chemicals inside of them. So basophils are big promoters of the inflammatory response. And the inflammatory response is all about increasing blood flow to an area where there's an infection and then helping the endothelial cells sort of separate so that the white blood cells can do that emigration thing. That's really what inflammation is about. And basophils help promote that because two of the substances that are in the granules are pro-inflammatory chemicals. Histamine is a well-known inflammatory chemical. And then also, strangely enough, serotonin. Now, if you've been keeping score or you remember anything from A&P 1, where in the body do you think of when I say the word serotonin? The brain, okay? Serotonin is famous for being a neurotransmitter in your brain, okay? Some people refer to it as like the happiness chemical, all right? It's the neurotransmitter that a lot of antidepressants work on by modifying their levels, like Zoloft, Prozac, etc. Those are what are called selective SSRIs, selective serotonin reuptake inhibitors. So usually you think of serotonin as being this neurotransmitter in the brain, but it's also the same exact chemical is released by basophils, and in that context, it actually has a pro-inflammatory effect. What's heparin? Anyone know what that is?
Is that something with the liver?
It is made by the liver. Somebody said it. What is it? Clotting? Okay, so does heparin cause clotting or prevent clotting?
Prevent clotting.
It prevents it, okay? It's a blood thinner. It's an anticoagulant. And the reason for it is that during an inflammatory response, sometimes clotting can get in the way of white blood cells being able to move and show up and get to where they need to. So long as it's localized and you don't have a whole bunch of heparin just being released in your blood, heparin can be a good thing in terms of allowing the emigration for the white blood cells to get there, etc. Basophils are similar to a tissue cell called a mast cell that you may remember from A&P1. The mast cells are very common connective tissue cells, and they release a lot of the same chemicals like the histamine, the heparin, but then also some enzymes called proteases. So they have a lot of similarities to basophils, but the difference is these guys are always in your tissues. They're already there, and then basophils are in the blood, and they have to kind of be called to the area. If you go back to that family tree of the blood cells that we looked at last week, wherever it was, this thing, notice here's the mast cell. So the mast cell is a tissue cell, but it's actually coming from sort of the same bloodline as actual blood cells, right? Here's the basophil, right? So these two guys, very similar. This guy circulates in the blood. This guy is already hanging out mostly in connective tissues. Mast cells are some of the first guys to like sound the alarm. When you have an infection someplace, chances are there'll be some mast cells nearby, and they'll be the ones that'll like freak out and pull the alarm, like, oh my God, there's bacteria here, or there's viruses, help. All right. So yeah, that's that. Then we go into the agranular leukocytes. The first one is the monocyte. Monocytes, what should you know about them under the microscope? Well, first of all, they are the biggest white blood cells. Notice over here, just as a point of reference, these are all red blood cells, and you can see how huge the monocyte is relative to the red blood cells. I mean, most of your white blood cells are bigger than your red blood cells, but these guys are really, really big, okay? So that's one thing. Another key feature that they always describe about them is this thing called the horseshoe-shaped nucleus, okay? It's not partitioned into little lobes the way that the nucleus is in the neutrophils or in the eosinophils. Instead, it kind of looks like this bent intertube, or it looks like a horseshoe, or sometimes it's described as looking more like kidney-shaped. Okay. These guys are still pretty uncommon, but I think if you put your mind to it, you'll probably find some today. Almost 1 in 10, or up to 8% of your white blood cells are going to be these monocytes. Now, one of the reasons why monocyte levels are fairly low in the blood is because they are constantly leaving the tissues and turning into those guys that I mentioned before, those macrophages. Macrophages are resident immune cells. They're present in many different organs of the body and different tissues. We'll talk a lot about macrophages again in the class. There's some specific names for macrophages in your lungs. There's another name for them when they're in your liver. But macrophages are kind of hanging out long-term in your tissues, and they're just waiting as kind of a local police force to make sure that they can do their job. But all macrophages ultimately have come from monocytes. So monocyte levels never really get that high in the blood because they're constantly leaving and they're turning into these macrophages. And if you go back once again to that silly family tree, notice here's the monocyte, and you can see the arrow to it coming down and becoming the macrophage. Again, when you hear macrophage or when you hear neutrophil, think phagocytosis. They love gobbling up bacteria and viruses. And then the last white blood cell to know, the lymphocyte. First of all, it's the second most common, right? Remember the memory trick, never let a monkey. So these are the second most common. You're definitely going to see some lymphocytes under the microscope today. Okay, they make up up to like 1/4 of all your white blood cells. Lymphocytes are the smallest white blood cells. And a lot of times they're about the same size as red blood cells. Okay? Sometimes they're a little bit bigger, but sometimes they're about the same size, just depending on how old they are. Lymphocytes are usually very round, and they usually have a big, round, purple nucleus that takes up almost all of the cytoplasm. So you look at this lymphocyte, there's that huge purple nucleus, and there's only a very thin rim of cytoplasm. Okay? So look for cells like that, and that's going to be a lymphocyte. Sometimes, I'll just tell you, just to give you a heads up, sometimes it's hard to see that thin rim of cytoplasm, and all you end up seeing is essentially this big purple nucleus. And if you don't have that thin rim of cytoplasm and you only see the nucleus, sometimes students can get this confused with a basophil. All right, so just a heads up, today you'll probably find some lymphocytes and you'll think it's a basophil, especially if I don't want to give you money, okay? So no, I'll be honest. If it's truly a basophil, I will say it. I promise I will say it. I'm not that cheap. I will say it, and then we'll have fun and you get $1, and then you can just invest it or whatever the hell you want to do. Lymphocytes are the main soldiers in immune system battles, at least as the battles drag out. They're not the first cells to get involved in your body defense. That's usually going to be things like the neutrophils and the macrophages. But they do, as an infection progresses, they do become the main soldiers in these immune system battles. And one thing that sets the lymphocytes apart from the other white blood cells is they are specific defenders. Most white blood cells are non-specific defenders. What the heck does that mean? Most of your white blood cells will attack anything, any bacteria, anything that does not look like a part of you, and they will check the markers on the surface to make sure it's not part of you. And if the markers are not your own, then most white blood cells will just attack it, and that's it. These guys, on the other hand, they take it one step further. They look at the markers, and they try to identify what the specific bacteria or virus is that you're infected with. Okay? The other white blood cells don't care. The other white blood cells just know it's not a part of you, and they'll attack it. But these guys actually try to figure out what specific virus or what specific bacteria you're infected with. And then only the lymphocytes that are designed to fight against that particular bacteria or that particular virus become activated. All the other lymphocytes that were designed to fight against different bacteria viruses, they basically have the day off and they don't do anything. Okay? So it's what's, you'll learn about it later, but it's what's called specific immunity or adaptive immunity. Okay? And that's the lymphocytes. 3 main types of lymphocytes: B cells, T cells, and then natural killer cells. Any questions about the white blood cells? We're pretty good with that. All right, platelets then. Platelets are not cells. They're pieces of cells. They're pieces of these big cells called megakaryocytes. One megakaryocyte ruptures into thousands of pieces, and each one of those pieces becomes a platelet. When you hear platelet, you should think that H word, hemostasis. Platelets are all about stopping blood loss when you damage a blood vessel. So when you have some, injury, there's a very good chance that you're going to tear a blood vessel, since blood vessels are all over the place in your body. And when you tear a blood vessel, you don't want to lose any more blood than you have to. So you want to stop the bleeding as quickly as possible. And one of the first things that happens is platelets will start sticking to that hole, and they'll attract more platelets, and the platelets will stick to each other, and pretty soon you'll have a big clump of platelets called a platelet plug. And sometimes, depending on how big the hole is, sometimes a platelet plug can do a pretty good job at plugging the hole completely. Okay, but besides just making that plug, the platelets will also release chemicals that'll help with the actual blood clotting step. And they also release chemicals that cause the blood vessels to constrict, which I'll show you in a second, will help prevent more blood loss too. So just bear that in mind. We're going to come back to the platelets when we do the hemostasis section, but I just want to mention them now. Stem cell transplants from bone marrow and cord blood. So when you have a patient that has some disease of their bone marrow, it's going to affect their ability to make new blood cells. Okay? It may severely affect it, and they may, bless you, they may run short on red blood cells, and that could leave them with an anemia. They can't carry enough oxygen around. They may run short on white blood cells. That's called leukopenia, and then that's going to leave them prone to infections because they don't have enough white blood cells. So, being able to make blood cells properly is obviously super important. And people that have diseases of their bone marrow, you got to do something for them to help them out. And these 2 treatments will address their problems. The first step with either of these treatments, whether you're using bone marrow or whether you're using cord blood as the transplant, the first step is to destroy the patient's bad red bone marrow. So give them either high-powered drugs intravenously in the form of chemotherapy, or give them focused radiation therapy, and that hopefully will wipe out all of the patient's own bad bone marrow. Then the next step is to infuse into them some healthy, fresh, new red bone marrow. Now, where that bone marrow comes from, and whether it's bone marrow or whether it's cord blood, that's an important decision. If it's going to be a bone marrow transplant, you could get it from another person, okay? And of course, the risk with that is just like when you get any kind of a transplant, whether it's a kidney or it's a heart or it's a lung or whatever, you always got to worry about like rejection, okay? Because the markers that are on the cells from another person are never going to be exactly like your own. And so your body will see it as foreign, and your white blood cells will try to probably attack it, okay? Now, hopefully, you've destroyed most of the patient's red bone marrow, so hopefully there's not a lot of their own white blood cells even left. But eventually, there's a strong likelihood that they will start to develop their own white blood cells over time. So when you get a transplant, again, whether it's bone marrow, whether it's a kidney, anytime you get a transplant from another person, you have to be put on immunosuppressive drugs that basically kind of calm down your immune system and say, hey, look, we know this is not really your own cells, but listen, can you just deal with it, okay? Because if you don't, you're going to die, okay? So that's when you have to go on drugs like prednisone and some of those other nasty immunosuppressive drugs. They have a lot of bad side effects, but the alternative is, not being able to live, and so that's the thing. Now, the other place, though, that you could get the transplant from is actually from yourself. If you have a disease of your bone marrow that's a non-cancerous disease, there's other types of bone marrow diseases that are not leukemia, that are not other cancers. And those kind of diseases, you can have flare-ups of your disease where like your bone marrow is affected and it doesn't do so hot, and then you can have quiet periods where your bone marrow is okay and it seems to be doing fine. In those people, if that's the type of disease you have, you can take a sample of their bone marrow during one of their disease-free periods while they're in remission, okay? Take a sample of their bone marrow when their bone marrow looks good, and then freeze it. Store it up, and then if they do have a flare-up of their disease in the future, then you can take that good marrow that they had given previously, take it out of storage, and reinfuse that into them. And that has the advantage of not having to worry about the immunosuppressive drugs because you're getting it from yourself, basically. Okay. Possibilities with bone marrow transplant. There's always the possibility that maybe you don't destroy the patient's bad red bone marrow first, and if they have any white blood cells, especially T cells, that are still living, that could attack the graft, or the graft is just another term for the bone marrow that you're getting. It could attack it and cause a rejection, just like it can with like if you're getting a kidney or anything like that. The other possibility, because you're actually giving them some new bone marrow, is that some of the T cells in that bone marrow itself could actually attack the host body, and that's a different problem called graft versus host disease. So, it's just again something to be aware of. Neither of those problems should occur if you're getting the transplant from yourself. If you're getting it from bone marrow that you stored up, neither of those problems should be an issue. They should only arise if you're getting it from another person. The alternative to bone marrow, in a newer thing than bone marrow, this is how they get the bone marrow. I believe they can go into other areas as well, but the iliac crest, which is part of your hip bone, is a common spot. They have this big needle, this biopsy needle that they put in, and they got to crunch it all through the bone and get the tip of it into where the spongy bone is, because remember, that's where the red bone marrow lives, inside the spaces of the spongy bone. Anyone in here? Yeah, go ahead, Nicole.
Well, I was just going to say, this is like the same process they'll do if they can't get an intravenous vein, right?
They do that sometimes, that's true. Yeah. Has anybody ever had them that wants to share, had them crunch through bone like this? Yeah, I mean, I haven't either, and I mean, I don't know if I'm trying to think if I've actually ever seen this done. I guess I haven't seen it done, but in theory, it's not supposed to be that bad, provided that you put some local anesthetic on the skin first where you're gonna be, this is a huge needle, but the local anesthetic will have a very small needle. You numb up the skin with local anesthetic. You also have to make sure that the needle of the local anesthetic goes deep enough to numb up the periosteum that covers the bone, because that'll have a lot of pain receptors in it as well. But if you can numb up those two places, then in theory, when you put this big biopsy needle in, it shouldn't be all that painful. There's not a lot of pain receptors in the actual bone tissue itself. It's mostly in the skin and in the periosteum that surrounds the bone. Now, in theory, I would think you'd still hear the crunching. You might want to like bring some earplugs and put earplugs in so you don't hear the crunching sound, but you shouldn't feel too much pain. Cord blood is another way to do it. Instead of using bone marrow, you're using samples of cells that are harvested from the umbilical cord. 30, 40 years ago, I don't know when exactly, they figured out that the umbilical cord has a lot of stem cells in it. Some of those pluripotent stem cells that have the ability to become, among other things, your blood cells. And so if you have an umbilical cord, you can process it and you can get those stem cells out, and then you can use those as the replacement for the patient's bone marrow. And the good thing about that is that they now have, I mean they've had for a while, but they have cord blood banks where people have donated their umbilical cords from their babies or whatever, and they create these cord blood banks, and the stem cells can be frozen until they're needed. And in theory, they can be frozen and stored indefinitely. Okay, so there's a good, there's cord blood banks all throughout the U.S. That are there just for this purpose. They still have to they do still have to check for compatibility and things like that between the donor and the recipient. But there's some advantages that you can see up there: higher number of stem cells, lower risk of graft versus host disease, less likely to transmit infection. When you take an umbilical cord from after a young baby's born, the baby hasn't really gone out and experienced the world yet like we have, so it's less likely that the tissue harbors any kind of infection like it might in an adult if you were getting a transplant from another adult. I will say that they have to be careful about storing this stuff though. I think it was 5 years ago, there was a cord blood bank in Pennsylvania, and this story may not be exactly right, but just roll with it. There was some janitor, in other words, accept my lie. There was some janitor, we'll say, who was working late hours, and I don't know, maybe he had some tunes on. He wasn't really paying attention. He's doing this with his his mop or whatever, and he tripped over or kicked out the cord that goes to all the refrigerators in this blood bank place, and no one noticed it. It happened on a weekend or something. No one noticed it for 48 hours, and all of the cord blood samples in that bank were dead and unusable. This happened 5 years ago at some places. There's certain details in that story that embellish, but it's more or less true. Yeah.
I have a question. So, what's the difference between the cord and the placenta? So does the placenta not have any stem cells, or is it just because the cord is directly attached?
No, I think the placenta does as well. I think all of that tissue probably has some stem cells in it. Why do they call it? Why don't they call it placenta banks or whatever? I don't really know.
Is it just because the cord has more of the stem cells?
I think so. There's a type of connective tissue, I think, called Wharton's jelly that's inside the cord that's maybe really rich in some of these stem cells too. That's the other thing. Yeah. All right. Hemostasis then. Hemostasis, what does the prefix hemo mean? Blood. What does stasis mean? Means or pause, or to hold steady, or to hold stable. So this is holding the blood stable, okay? Basically, it just means stopping blood loss as quickly as possible after you've torn a blood vessel, all right? Throughout the day, there's little things that you're doing, where you run the risk of damaging the little blood vessels, all right? Maybe you just sat on your ass too fast, right? Going into a chair and you burst a few blood vessels in your butt. I don't know. There can be little things. It doesn't have to be like a torn aorta with like, blood spurting out, or, not like a femoral artery that got stabbed and it's like, it can just be like a little blood vessel, all right, here or there. And your body needs to quickly, control the blood loss through these blood vessels. And the response has to be fast, and it has to be localized to where the damage is. That's the real concern. Hemostasis, a lot of it involves a positive feedback system. And as you know, positive feedback systems have the ability to get stronger and stronger and, more severe. And one of the things with hemostasis is hemostasis can potentially start out where the damage is, but it could potentially spread and you could start getting clots in undamaged blood vessels. And that's a really bad situation. So you want the repair and the hemostasis to be localized only to where the damaged area is. And we'll talk about what it's called when you get clots forming in undamaged blood vessels. That's a serious thing. So 3 things involved in hemostasis. First, vascular spasm, then formation of a platelet plug, and then lastly, the actual blood clotting. So 3 things, okay? So when somebody says like hemostasis, it's not technically the same thing as blood clotting. The way I would look at it, I would say that blood clotting is just one of 3 parts of hemostasis, okay? So first, vascular spasm. What does that mean? That means that the blood vessel, prior to where the hole is, will tighten up in order to reduce the amount of blood flow through the damaged blood vessel. Let me show you a picture of that. Or let me draw a picture of that. So you got a blood vessel. Okay? We'll say the blood is flowing in this direction. Okay? And let's say you have an injury and you have a hole right here in the wall of the blood vessel. So in theory, blood could be coming and then it would go right out through that hole and you'd start losing blood, right? What's going to happen is that just prior to that hole, the blood vessel will constrict. Okay, now you haven't learned about blood vessels yet, but blood vessels usually have a layer of smooth muscle in the wall and they can tighten up. So just prior to that hole, you'd expect to see the blood vessel there kind of constricting so that it's going to narrow the opening and kind of make it look like this. And when it tightens up like that, the blood will seek another path to travel by. Instead, more blood will start then flowing down that way, and less blood will be flowing that way where it could potentially go out through that hole. Okay? So vascular spasm helps a lot. It's kind of diverting the blood flow away from where the damaged area is. Okay? That's number 1. Number 2 is this thing called the platelet plug that I mentioned. So the cells that line the inside of the blood vessel, they're called endothelial cells, or it's referred to as endothelium. When the endothelium is undamaged, platelets have no interest in it. Platelets won't do anything. But as soon as you damage that endothelium, platelets all of a sudden be like, oh, that looks interesting, and they'll start showing up and they'll start sticking to that area where the damage is. And pretty soon they'll release chemicals that'll cause more platelets to show up, and then the platelets all stick together and they form this big thing called a platelet plug that will help to block off the hole in the blood vessel. And depending on how big the blood vessel is or how big the hole is in the blood vessel wall, sometimes the platelet plug does a pretty good job at just completely stopping blood loss. Okay? But in order to fully repair the blood vessel wall, though, you have to go into step 3, which is the blood clotting, also known as coagulation. And this is probably the toughest part to understand about hemostasis. And it's not that bad, but it's just a little bit trickier than the other 2 things. So let me go through this. Basically, blood clotting is a series of chemical reactions where one reaction leads to the next reaction, which leads to the next reaction. What do you get at the very end of blood clotting? You get something that looks like a net, okay? So it's going to look like this. Okay? And that's made out of a protein called fibrin. So the goal by the end of blood clotting is to create this fibrin net. And what this net will do is it will attach to where the hole is, and it'll basically block off the hole. So if this is where the hole is, right? It basically kind of almost like a patch that's covering up the hole. And that net will do two things. It'll trap and it'll stop red blood cells, white blood cells, and things from being able to move out. That'll help. And then also, the edges of that net will attach to the edges of the blood vessel wall, and over time, will kind of pull the edges of the wall together so that the wall can repair itself. And that's referred to as clot retraction. We'll talk about that too. So, how do you get though to that fibrin net? The answer is you got to go through 3 stages. And here's the picture. Now, there's a lot of little details over in these pictures, but these are the different stages. So this is stage 1 in green, this is stage 2 in brown, and then this is stage 3 in pink. You don't have to remember every single little step here, but what I do think is important is to know what you get at the end of each step, because what you get at the end of one step is then going to be used in the next step to make the next step happen. So at the end of the first step, or the first stage, whatever you want to call it, you get a chemical called prothrombinase, okay? Prothrombinase is then used in the second stage to convert prothrombin into thrombin, okay? And then the thrombin that you get at the end of the second stage is used to convert fibrinogen into that fibrin that I was talking about, okay? Also, the thrombin will turn on another factor called factor 13, and that further helps to make that net even stronger, okay? But that's the end goal, is getting this nice, strong fibrin net. And 3 stages: first you get prothrombinase, then you get thrombin, and then you get this fibrin net at the very end. Now, the first stage is the trickiest stage, and you don't have to remember every little step up there, but you should know that in the first stage, you have 2 choices for how you get that prothrombinase. You can either follow this pathway on the left, called the extrinsic pathway, or you can follow this pathway on the right, called the intrinsic pathway. What's the difference? Well, it basically depends on how severe the damage is to the blood vessel wall. If you have an actual hole that goes all the way through the blood vessel wall, then you'll follow the extrinsic pathway. And the reason being is because sitting outside of the blood vessel, sitting in the tissues, is something called tissue factor. And when you have a hole that goes all the way through the wall of the blood vessel, the blood starts getting exposed to this tissue factor, and that'll trigger this extrinsic pathway to happen. So the reason it got the name extrinsic, it's because it's triggered by a chemical called tissue factor that is extrinsic to, or outside of, the blood vessel itself. It's not inside of the blood vessel, it's outside of the blood vessel. That's why it's called extrinsic. And the only reason why the blood would ever be exposed to tissue factor is if you have an actual hole all the way through the wall of the blood vessel, okay? The intrinsic pathway, as you can probably guess, takes place with less severe damage. Like maybe you've just roughened up the endothelial cells. The endothelial cells are the inner lining of the blood vessel, but there are some other layers as well. So maybe you just roughened up the endothelial cells, but you don't have an actual hole yet. Then you trigger the intrinsic pathway. The intrinsic pathway has more steps to it, it's more complicated, and it's called the intrinsic pathway because everything that's needed to make it happen is already inside of the blood vessel, okay? It doesn't rely on some chemical like tissue factor that's outside of the blood vessel. All the stuff that's needed to make it happen is already inside of the blood vessel, okay? Again, it really doesn't matter which route you go. The end result is the same. You get this chemical called prothrombinase. Okay? Prothrombinase is then used in stage 2 to convert prothrombin into thrombin. By the way, you should know that these names up here, I'm not going to make you memorize it, but you should know that these different clotting factors like prothrombin and thrombin and fibrinogen, they go by their names, but some jerk along the way decided they should all have their own number as well. So Prothrombin is also known as clotting factor number 2, and fibrinogen is known as clotting factor number 1. And then there's actually a clotting factor 13, and there's clotting factor 10, 11. You don't have to memorize all that stuff. Just be aware, though, that they do use numbers sometimes instead of these names. Thrombin from stage 2 is then used in stage 3 to convert the fibrinogen into sort of some loose fibrin threads, and then to really help it form that nice, strong net, thrombin will also turn on factor 13, which then helps with that. Okay? Any questions about any of these stages or steps? Nicole?
So the extrinsic, that is when like the bleed is a little more severe?
Correct.
Through the vessel? Okay.
Yep. Extrinsic is when it's more severe. Intrinsic is when it's less severe. Yep. All right. Now, as I mentioned, once you have this fibrin net, or whatever you want to call it, it will attach itself to where the hole is, and it will gradually start pulling the walls of the blood vessel together, and that's called clot retraction, and that will allow the blood vessel wall to heal itself up. Okay? Eventually, the blood vessel wall is going to have to repair itself, and this is helping with that. And notice, in the meantime, the net is also preventing things from, like red blood cells from being lost, or white blood cells, etc. It's trapping them inside of the blood vessel. One thing to know about, well, there's a lot of things to know about blood clotting, but one of the most important things to have in your diet, if you want to clot your blood properly, is vitamin K. Vitamin K is a fat-soluble vitamin. Anyone know the other 3 fat-soluble vitamins? A, D, and E, and K are the fat-soluble vitamins, which means like the B vitamins and vitamin C, those are water-soluble. But anyway, vitamin K is a fat-soluble vitamin. It's super important for blood clotting because your body needs vitamin K to make 4 of the clotting factors. Which 4? Well, I'm just going to give you their numbers. You don't have to memorize their names, but their numbers of the vitamin K dependent clotting factors are 2, 7, 9, and 10. Okay? Those are the vitamin K dependent clotting factors. That just means that if you don't have vitamin K in your body, you cannot make those clotting factors. And that means you're not going to be able to clot your blood very effectively. So, not having enough vitamin K in your diet can lead to, like, problems with bleeding, uncontrolled bleeding. Now, strangely enough, there is a medication that works as an anticoagulant that's based on the vitamin K clotting factor. Does anyone know the medication that is an anticoagulant that's based on the vitamin K clotting factors? Warfarin. What's the other name for warfarin? Coumadin. Warfarin or Coumadin, I'll write the name up here. Sorry, warfarin, also known as Coumadin. Okay, warfarin, or I don't know why I made this first R so big. Sorry. OCD. Anyway. Warfarin or Coumadin is a drug that works by preventing your body from making the vitamin K dependent clotting factors. It blocks your body's ability to use vitamin K in order to make those factors. And it's a fairly common anticoagulant drug. So it prevents your body from being able to clot, and the mechanism is by preventing the formation of factors 2, 7, 9, and 10. Okay? Warfarin, or Coumadin, whatever you want to call it, used to be a pretty popular drug for people that had a heart problem called atrial fibrillation, or AFib. You may have heard of that. Atrial fibrillation is a problem where the atria of the heart don't squeeze like they should. Instead of contracting like they should, they just kind of vibrate. And so blood can kind of hang out a little too long inside the atria. It kind of collects inside the atria. And as blood sits around, bad things can happen, and clots can start to form when blood is not moving properly. So in people with AFib, they're at risk for developing clots inside the atria of their heart. And in order to prevent that from happening, you'll usually put them on a medication like Coumadin, as a precaution. Obviously, if you can, you'll also give them medications or you'll do treatments to try to correct the heart arrhythmia, right? You'd like to be able to fix the AFib, but a lot of times you can't correct it completely, and just as a precaution, you put the people on Coumadin to prevent that from happening. Okay? But Coumadin is also a very dangerous drug because it has a narrow therapeutic window. It's very easy to go a little too high, and then you make the patient have uncontrolled bleeding. So yeah, in people that are on Coumadin, they usually have to do regular blood tests to make sure they're at right dosage, that they're preventing the bad clots from forming, but not impairing their ability to make good clots. Okay. So hemostasis, it's great and all, but it's also dangerous because it's based on a positive feedback cycle. Once you have a blood clot, it will tend to get bigger. It'll tend to cause other clots to form that could potentially form in places that you don't want them. You don't want a clot forming in an undamaged blood vessel. If you look back at the picture, look back at this picture, here's the positive feedback system I'm talking about. Notice, here's your thrombin. See those green arrows that are going up with the plus signs to them? What that's telling you is, once you have thrombin, it will tend to go back up to these other steps and make them happen faster. So more thrombin, more prothrombinase, which leads to more thrombin and more prothrombinase, and it just keeps amplifying like a positive feedback system. So that's pretty dangerous. Fortunately, to help, you've got something called the fibrinolytic system that's in charge of dissolving inappropriate clots, breaking down the clots that are not in places where you want them to be, okay? Another part of the fibrinolytic system is that built into your clots is a protein called plasminogen. And it's almost like a self-destruct bomb that's built into your clots. And as the clot gets larger, the plasminogen can be converted into a chemical called plasmin, which then actually sort of causes it to eat away at itself and dissolve the clot. So that's another safety mechanism to prevent clots really from getting too large. Other things that can help prevent abnormal clots, I mentioned that thrombin does work on a positive feedback system, but once you get that fibrin net at the end, that fibrin will also absorb any extra thrombin and prevent it from basically doing anything further. So it takes the thrombin and localizes it to where just the damaged blood vessel is, so that the thrombin isn't freely circulating around in your blood where it could cause abnormal clots. Good blood flow will cause the clotting factors to kind of disperse throughout the blood, okay? Clotting factors are relatively safe except when they are able to kind of sit together for a long period of time, and then they'll start to interact, and that's when you can start to get blood clots forming, okay? We'll talk more about that on the next slide. And then another thing that helps prevent abnormal hemostasis is the endothelial cells and the white blood cells produce a chemical called prostacyclin that actually prevents platelets from sticking to the blood vessel wall. So when you have a normal, undamaged blood vessel wall, the endothelial cells make this chemical, and that stops the platelets from attaching to it. Once the blood vessel wall becomes damaged and the endothelial cells become damaged, they no longer make the prostacyclin, and that's what is going to cause the platelets to be and they'll start sticking to that area, okay? So long as the blood vessel wall is nice and intact and the endothelial cells are still there, they'll basically release this chemical that'll tell the platelets to kind of stay away. Don't stick to me, I'm not a problem, you don't want to stick here. By the way, anyone know what organ they first identified this chemical in?
Prostate.
There you go. Now, I mentioned abnormal clots or bad clots. Bad clots are called thrombi, or that's the plural form. The singular form is thrombus. The problem is called thrombosis. This is when you have a clot forming in an undamaged blood vessel, okay? Usually it happens in veins because blood flow, as you'll learn later, is usually more slow in your veins. Blood kind of pools in your veins and it doesn't move as quickly as it does through your arteries. And anytime the blood just kind of sits around, there's the potential that those clotting factors will interact and they'll form a thrombus, okay? Probably the most common place is to have a thrombi form in the veins that are like in the calves of your legs and things. And there's a name for that. Anyone know the name for that problem? Yeah, DVT, or a deep vein thrombosis.
Victor Wembanyama, he has this issue in his right shoulder.
Right. Yeah. So that's right. He has a blood clot right up in his shoulder, and he's out for the season, right? Yeah. Yeah. I'm not exactly sure what all the mechanisms are. I mean, there's a lot of healthy people that get like clots and things like that, like NBA players and stuff like that. I don't know.
Could their height be a factor on that specifically?
It might be. I mean, yeah, he's huge, right? What is he like?
7'5".
Oh, he's 7'5"?
Yeah,
I thought
he
Zach.
does. 7'4" and a bit, yeah.
Yeah, I just heard that Zach Edey was the tallest NBA player.
No, that's Victor.
And I don't look that up.
No,
Get back to it.
Cavs fan.
He's 7'4".
Is he?
I know my Purdue basketball. He's 7'4".
Well, no, but Wembanyama is he's like 7'5".
He's just thin, and it makes him look taller.
Yeah.
There you go. All right, we'll settle that later. But for now, what happens when an abnormal clot forms? Well, it might be like maybe the surface of the endothelial cell is roughened a little bit, not really damaged, but like even if the endothelial cell surface looks a little bit odd, that can trigger a clot to form. And one of the most common things is atherosclerosis. Atherosclerosis is buildup of cholesterol and other lipids and things in the walls of your blood vessels. It's one of the reasons why they always want you to keep your blood cholesterol levels low and all this other stuff. Once atherosclerosis shows up, it creates a roughened surface that platelets then start looking at, and they're like, oh, wait, let's start sticking to this area. Next thing you know, you've got like a clot forming in one of those areas. So, keeping your cholesterol levels in check. Also, another thing that can damage the blood vessels is the inside of the lining is high blood pressure. So keeping your blood pressure down, keeping your cholesterol levels low, you're less likely to develop atherosclerosis, which then will make you less likely to develop these thrombi. Again, blood sitting around, moving too slowly is a prime situation that will lead to these clots forming. So, what can you do to prevent it? Have nice, smooth blood vessel lining with smooth surfaces, no atherosclerosis. Have good circulation. Have the blood pumping through. One of the best things you can do to prevent like the clots in your calves is what? What can you do to prevent just walking or compression stockings? Every time you walk, you're contracting the gastrocnemius and the other muscles that are there. The veins of your legs, they're running through those muscles. And every time you use the muscles, it's squeezing the blood through the veins so that the blood is not sitting around too long. So, you hear about people getting clots in their legs like on long air flights, right? From sitting in one spot for too long. One of the best things you can do is just to periodically get up, stretch your legs, walk around a little bit, do some things like this with your ankle just to contract those muscles, keep the blood flowing, okay? Again, in some people are at increased risk for clots because they have a disease like atrial fibrillation. And in those patients, you might actually want to consider going an extra step and giving them medications like Coumadin that will prevent the clot from forming in the first place. The worst thing about these clots, these thrombi, oftentimes is not what's happening in the vein of the leg, all right? The worst thing is what? What are you concerned about if you have a clot in the veins of your leg? Traveling. You're worried about the clot breaking off and traveling, and that's called an embolus, okay? And an embolus is kind of a big deal. And basically the way it works is you got a clot someplace in the veins, usually in your legs, and then a piece of it breaks off and it travels, and that's called an embolus. And you have to know your anatomy a little bit, but I'm going to walk you through this. Where, if you have a clot that's, say, in the veins in your legs, and it breaks off, where is that clot, where's that embolus going to get trapped? Anyone know? Well, let me walk you through it. I know you don't know the blood vessels yet, but if you have a clot down here in the veins that are like in your calves, as it breaks off, it's going to leave and it's going to go up this way. And as it goes up, the veins are going to be getting bigger and bigger. So it's not going to get stuck here. As it goes through your thigh, the veins are getting bigger and bigger. It's not going to get stuck there. As it goes into your pelvis and in your abdomen, the veins are really big. It's not going to get stuck there, okay? It's going to go actually into the right side of your heart. The openings that are in the heart, they're really big. The openings between the chambers are really big, so it's not going to get stuck in the right side of your heart. But then it's going to get pumped out the right side of your heart, and what organ is it going to go to? Anyone know? Up here, when blood gets pumped out of the right side of the heart, it goes to your lungs. And from that point on, as you leave what's called the right ventricle, the blood vessels are getting smaller and smaller and smaller. And that's where an embolus is going to travel, most likely, if it's started in the veins of your legs and you get what's called a pulmonary embolism. And that's a huge cause of death in hospitalized patients, okay?
Chris Bosch, he had that. He had a blood clot.
That's cool, very awesome.
Yeah, no, you're right. He had it. Yeah, no, I mean, a lot of people, it's not an immediate death sentence. Not everybody's going to die that gets a pulmonary embolism, but depending on how big the embolism is or how many you're throwing, like there's no rule that says just one breaks off. You could have multiple clots breaking off and multiple emboli, as well as like if you take into account how old the patient is, what other diseases they have, it could easily be a fatal thing as well. And there's tons and tons and tons and tons of stories of people that are hospitalized for one particular problem, and while they're in the hospital and they're bedridden and they're not moving around, they get a DVT, next thing you know it breaks off, they get a pulmonary embolism, and they die from it. So it's a really big deal. Another question for you. Let's take one of those atrial fibrillation patients. Let's suppose that they didn't get their dose of Coumadin right, and they actually get a clot forming in the left atrium of their heart. Okay? Unfortunately, they got a thrombus forming in the left atrium of the heart. If that thrombus were to break off and become an embolus on the left side of their heart, where would the embolus get stuck? The brain. It goes right up to the brain, and then they get what's called an embolic stroke. Okay? And that's a huge deal, which is one of the reasons why they always put these AFib patients on anticoagulants, because they're so worried of that happening. Okay? All right. Finally, new topic. All right. Any questions about hemostasis?
Oh, we were right, by the way. Edie is 7'4".
I told you.
Yeah, I knew that
I
as
knew
well.
that. Well, how tall is Victor?
7'3".
Like 7'5", but
Wait.
No, he's 7'3". He's
Like, well,
X is capping.
well, okay, like I don't know, like that is like a big discussion in the NBA community. How tall really is he? Because people say 7'3", 7'4", 7'5".
Grab a
People say
measuring
7'5"
tape,
with
somebody.
shoes on, like-
That.
Yeah, could be the shoes,
I
right?
think 7'4".
Yeah.
I think most people say 7'4". Like
Yeah.
Google says 7'3". So.
Google says 7'3". All right. Well, we'll settle this later.
We'll
Anyway,
check that.
so let me go into the blood groups and the blood types quickly. So the name for your blood type comes from the type of protein or antigen that's on the surface of your red blood cells. Okay? Antigens we'll talk a heck of a lot more about in the lymphatic system chapter, but they're like little markers that are on the surface of cells. And you've got your own markers that are on your body cells. Bacteria have their own antigens, markers, etc. And most of your body cells have some kind of markers on them. Your blood cells, your red blood cells, have like probably about 100 markers. But they found that, at least clinically, in terms of like trying to give blood to a patient, you don't have to worry about matching all 100 markers. Okay? If you did, getting a blood transfusion would be as difficult as getting like a kidney transplant. You'd have to find a really good donor. They have found that so long as you match up 3 of the antigens, you can usually then give a blood transfusion safely to a patient. And so the 3 antigens that you could potentially have on the surface of your red blood cell are the A antigen, the B antigen, and the RH antigen. Okay? And if you can just manage to get a good match with those 3 antigens, you'll generally be okay. So let me go through these first. First, I'm going to talk about the AB antigens, then I will talk a little bit more about the RH antigen. So with the ABO antigens, there are 4 types of blood you can have, right? If you've got the A antigen on the surface of your red blood cells, you have type A blood. If you got the B antigen, you got type B blood. If you have both A and B, then you have type AB. And if you don't have either A nor B, then you have essentially type O blood. Or if you want to think about it as type 0, it means you don't have any antigens on the surface of your red blood cell. The other thing, the RH antigen, that's what gives you the word positive or negative. Like when somebody says their blood type, Jess before said he had O positive, right? The word positive or negative refers to whether you have this other antigen, the RH antigen. So if you say the word positive, it means you do have the RH antigen. If you say the word negative, it means you don't have the RH antigen. Now, one thing that's a little tricky, maybe for students sometimes to understand about blood types, is remember, blood is a connective tissue, and you can look at the cells, the formed elements, or you can look at the plasma. And with the ABO blood system, what's kind of interesting about it is whatever antigen you have on the surface of your red blood cell, you will have the opposite antibody against the other antigen in your plasma. So, antibodies are basically defensive proteins that can attach to antigens and then possibly destroy the cells that are connected to those antigens. So if you have type A blood, it means you have the A antigen on the surface of your red blood cells. But if you were to look in that person's plasma, you would see that they actually have antibodies against the B antigen. And vice versa, if you looked at a person with type B blood, they'd have the B antigen on the surface of the red blood cells, but then in their plasma, they'd have had anti-A antibody. And that's why you have to be careful when you give blood to different people with different blood types. If you try to give these red blood cells to a patient with type B blood, their anti-A antibodies would attach to the A antigen that's on those red blood cells and destroy them. And you'd have this massive, what's called transfusion reaction that could be really serious just depending on a number of factors. So you always got to remember that whatever antigen a person has on the surface of the red blood cell, they're going to have the opposite antibody in their plasma. If you have both antigens on the surface, then you're not going to have any antibodies. And if you have neither the A nor the B on the surface, then in your plasma, you'll have both antibodies. Okay? Now, when you give blood, like when you're at the hospital and you see like an order to give a patient some blood, the way that they usually transfuse blood, they give it in the form to what's called packed red blood cells, or PRBCs, okay? When you give a person a transfusion, you're not giving them usually what's called whole blood. Whole blood includes the cells and the plasma. Most of the time you're giving them what's called packed red blood cells, which is just the red blood cells. So keeping that in mind, you're usually just giving the red blood cells that are shown up here. And from that, if you think about it, people that have type AB blood, okay, they're known, what's the nickname for people that have type AB blood? The universal recipients, okay? If you think about it, a person with type AB blood, they can get red blood cells from anybody, okay? Because they don't have any antibodies in their plasma, they can accept any of these red blood cells. It doesn't matter what the antigens are on the surface. They don't have any antibodies in their plasma that would cause a problem once they receive those red blood cells. So they're the universal recipient. And then what's the nickname of people that have type O blood?
Universal donor.
Universal donor. Again, when you give blood, you're usually just giving the red blood cells. You can give the person with type O blood's red blood cells to anyone. There are no antigens on the surface of type O blood, so it doesn't really matter what kind of antibodies you have in your plasma. You can give those types of red blood cells to anybody.
I think type O blood is the the Red Cross, I think that's the type of blood, the blood group they need the most.
Yep.
Just because like that's the blood type out that you just said that anyone can receive.
And it's also, I mean, the good news is it's also the most common blood type too. Type O is the most common. Now, we're going to talk about blood typing, how you actually can tell the different blood types. There's some trays back there, and I'll let you try to do this yourself in class, and we'll discuss that in class. So I'm just going to skip that for now. Now, I wanted to show you this guy, but I'm running. I don't want to talk your ear off. I know I've already talked your ear off, so I'm not even going to tell you the backstory because, frankly, I wasn't going to test you on it anyway. But I do want you to see that I had this guy. He was involved in coming up with the blood types, and he was pretty famous, and he made a lot of money. And then there was this guy who was not so famous, and he didn't make as much money. And because of that, it was rumored that he cried blood, and so I did this. It took me like 6 hours to get this right, so I hope you appreciate that. It's like, you see what I did there? It's like crying blood. You're like,
He's crying.
all right, that's cool, right?
Crying blood.
Anyway, you're just lucky I'm not going to tell you the whole story. All right, so let me move on. RH incompatibility. So let's talk about the RH now. When somebody says, their blood type, if they say the word positive, that means they have the RH antigen on the surface of the red blood cells. So a person that say, AB positive, they're going to have everything. They're going to have the A antigen, the B antigen, and the RH antigen, right? Or if a person says they're O negative, those individuals aren't going to have anything. They're not going to have A, they're not going to have B, and then the word negative means they also don't have the RH, right? So the word positive, the word negative means whether you have the RH or not. Now, one thing that's different with the RH system than the ABO system has to do with the antibodies that you find in the plasma. With the ABO system, you will always have antibodies against the antigen that you don't have. But with the RH system, it's different. The RH system, none of us naturally have anti-RH antibodies. It doesn't matter if your blood cells are Rh positive or if they're Rh negative, we naturally do not have anti-Rh antibodies in our plasma. None of us do. Unfortunately, that doesn't mean that we can't develop anti-Rh antibodies if the conditions are right. And what can happen is that you can then develop what's called Rh incompatibility, which would happen if a person has developed anti-Rh antibodies and they're getting blood that's Rh positive. That's when you could have Rh incompatibility. So how can a person develop anti-Rh antibodies? The best example, the most common example they always give is pregnancy. If you've got a woman who is Rh negative and she's carrying a baby that's Rh positive, okay? Now remember, naturally speaking, a woman, all of us, we're not going to have anti-Rh antibodies. So this woman, she's pregnant, she doesn't have any anti-Rh antibodies yet. During the pregnancy, the placenta does a really good job of keeping the blood separate. So during the pregnancy, the mom's blood is not going to mix with the baby's blood. Fine, no problems. But at the time of delivery, spoiler alert, at delivery, it's messy, and there's a lot of body fluids that are mixing, and things are being torn, and blood is everywhere, and it's all gushy and gory, and all this crap's mixing around. At the time of delivery, there's a very high likelihood that maybe a little bit of the fetus's blood will mix with the mom's blood. And if that happens, if the fetus's blood is Rh positive and the mom's blood is Rh negative, and she's exposed to that fetus's blood, it will trigger her body to react against that and start making anti-Rh antibodies. Now, is that a problem for that baby? No, that baby just came out. That baby's like, see ya, they're gone. They triggered the mom's system to make anti-Rh antibodies, but that baby's already been delivered. Who's it a problem for? The next baby, okay? If she gets pregnant again with another Rh positive baby, then those antibodies that were created, those anti-Rh antibodies that were created during the first pregnancy can potentially cross the placenta and destroy the red blood cells of that second baby. And that, that could lead to loss of that baby. And that's called hemolytic disease of the newborn. And it's a really serious thing. So, what can you do for those women to prevent that from happening? Well, it's on the next slide, but don't cheat. All right. Anyway, what you can do is you can stop her body from ever making those anti-RH antibodies in the first place. During the time of delivery of that first baby, you want to treat the mom with a drug called Rogam. Okay? This is not what makes your hair grow back. Okay? It's Rogaine. But Rogam is a chemical that you treat the mom with at the time of delivery, or maybe a little bit before the delivery, maybe again at the time of delivery. You might give a couple of doses of the first baby. And what that'll do is the Rogam will get into the mom's blood, and it will seek out any of the fetus's red blood cells that might have gotten into her circulation at the time of delivery. And it will destroy those fetus's red blood cells that are in her circulation before her own body has a chance to react against them and form anti-RH antibodies. So it's preventing her from making those antibodies so that then when she gets pregnant the second time, and if it's again with another RH positive baby, she won't have to worry about having any anti-RH antibodies that could cross the placenta and hurt that baby. Okay?
Is this a common thing that happens, or is this pretty rare?
Do you mean the problem actually turning out like it is, or giving Rogam?
The problem.
No, I think they're pretty careful in screening for that now, and I don't think you see it all that often. But in terms of the number of people that get Rogam, I think that's fairly high. Yeah. I mean, you know, again, there's going to be a lot of RH negative women, and there's going to probably be a lot of RH positive babies that they're carrying. So you have to be concerned with that. Yeah. I mean, and also too, I mean, it's not necessarily guaranteed, even if you have an RH positive baby and you're RH negative, it's not necessarily guaranteed that the blood will mix. It's just sort of a precaution just in case so that she doesn't develop these antibodies. Again, blood typing is done to make sure that you give the right blood type to the right patient so that you don't have an interaction between antibodies and antigens. Again, the antibodies will attach to the antigens and then destroy those red blood cells, and that's called hemolysis. And, you know, depending on how bad, the transfusion reactions can range from being like nothing, maybe like a slight increase in your fever for a little bit, for a few minutes, to all the way to being fatal. So they can run the gamut from very minor to like life-threatening, right? It's going to depend on like how much of the bad blood you gave them, like before you realized that you screwed up, or someone screwed up, how much of the bad blood did you give them? It's going to depend on obviously like their age, and then you know if you've got somebody that's say in their early 20s, they're probably going to do a lot better getting the wrong blood than say somebody that's in their 80s or 90s. And then obviously other diseases too. If it's a healthy person, they'll probably survive it a lot better than a person that's also got, diabetes and COPD and congestive heart failure and all these other things on top of it. The most common reason for getting bad blood or the wrong type is just like a clerical error, just like writing down the wrong type on the sheet or something. I'd like to think, I don't know the data on this, but like, after everything became like electronic records and all this other stuff in the, over the last couple of decades, I'd like to think that this clerical error thing has gone down. I don't know the exact data on that, but I would think it had. All right, lastly, some blood disorders. Abnormalities of erythropoiesis. Again, what's erythropoiesis? It means making red blood cells. So hemopoiesis is making all blood cells. Erythropoiesis is specifically making red blood cells. Anemia is when you can't carry oxygen as effectively in your blood, either because you don't have enough red blood cells, or maybe because the red blood cells themselves don't have enough functional hemoglobin inside of them. What can cause anemia? Well, maybe you have an iron deficiency anemia. That's a very common type. You can't make functional hemoglobin without iron. Remember, how many irons are in one hemoglobin? 4. So you gotta have enough iron in your system, right, in order to make hemoglobin. Hemolysis Maybe you've got some disorder where you destroy the red blood cells, okay? And that could be a factor. Autoimmune disease, maybe your white blood cells are attacking the red blood cells, could be something like that. Blood loss, if you lose blood, you're gonna, run short. Maybe you've got like a bleeding ulcer in your GI tract that you don't know about, or you got a bleeding polyp in your colon that you don't know about. Over time, that will start to drain your blood down and you can develop an anemia from that. Or maybe you've just got a problem making red blood cells in the first place. You've got some disease of your red bone marrow and you just, like a leukemia or something, you just can't make your red blood cells. So any of those things could cause anemia. Sort of the opposite problem, having too many red blood cells, is called polycythemia. And the problem with polycythemia is what? What happens if you have too many red blood cells? What happens to the consistency of your blood? It becomes too thick, okay? Your blood is thicker than water. I mean, that's a saying also, but your blood is thicker than water, but you don't want it to be too much thicker than water. And that's what can happen if you have too many red blood cells. And I mentioned this, I think, last week. Your body will release erythropoietin if you put your body into areas where there's low oxygen levels. If you go up to the mountains and start working out, like in Denver or wherever, or let's just go for broke, go to Everest. Go climb to the top of Everest and start working out, okay? You go someplace where there's low oxygen levels, your kidneys will be like, oh my God, the oxygen levels here are low, your kidneys release erythropoietin, and you make more red blood cells. And that's known as natural blood doping. You're training at higher altitude. And to my understanding, a lot of performance athletes still do that. Like if they're gonna run a marathon at sea level, they'll go someplace high altitude, make more red blood cells, then they'll come back to where the race is at sea level, and they'll have an advantage because they can carry more oxygen to their tissues better than, say, another competitor that didn't train that way. What's illegal, and what Lance Armstrong did, and probably other people, is giving yourself shots of synthetic erythropoietin, okay? That's illegal doping. And the problem with that is you can't necessarily know how your body's gonna react to a given dose of EPO, okay? If you do legal blood doping, your body's pretty good at knowing itself. Like if you just go up to a higher altitude, your body will know the right amount of red blood cells to make and it won't keep going it. But if you're giving yourself injections of a drug like EPO, you're kind of bypassing the natural control mechanisms in your system and you run the risk of creating blood that's way too thick. And the problem with blood that's too thick is it can't get through some of the little capillaries. If those are capillaries that are going to your heart, then you can have a heart attack. If they're capillaries that are going to like your brain, you can have a stroke, right? Iron deficiency anemia, the most common anemia in the US, mostly menstruating women. The problem with iron deficiency anemia is not having enough iron, and the reason why it affects menstruating women is because when you have your monthly cycle and you lose the endometrium and you lose that blood along with it, you're losing all that iron along with it too, okay? When red blood cells naturally die in your body, remember red blood cells naturally live for 120 days and then they die like in your liver or your spleen. When that happens, at least you can recycle the iron. But when you're losing blood from a menstrual period, you're not getting that iron back. So that's why it primarily affects menstruating women. That's why it's important for women to make sure they're getting enough iron in their diet. Hemorrhagic anemia, that just refers to anemia due to blood loss. Sickle cell disease, sickle cell anemia, is a disorder where you inherit the bad gene for hemoglobin. Specifically, it's a faulty B chain. And usually when the hemoglobin is attached to oxygen, the hemoglobin looks more or less normal. But when the hemoglobin gives up the oxygen, that's when it'll take on a weird shape. It'll become almost rod-like. And when the hemoglobin changes its shape, it causes the entire red blood cell to change its shape, and you get this sickling. Okay? Sickle cell disease, you can have like the full-on disease, or you can have what's called sickle cell trait, and it's just different versions based on how many of the red blood cells actually sickle, right? Some people have a blend between normal and sickled cells, and then some have more like completely like sickled cells. All right, any questions about any of this stuff?
I I
Yes.
just want to go back to about the deep vein thrombosis. Actually, you know, it's funny actually. Like a lot of NBA players in the past like couple years, it's not just Victor.